So I'm Dr. Ann Ogbenna. I'm lecturer in the University of Lagos and also a consultant hematologist in Lagos University Teaching Hospital. I'm a hematologist, but I also head the stem cell processing lab here in the Lagos University Teaching Hospital. So the stem cell lab is integral to successful bone marrow transplant in that, number one, it helps us to know, one, having the yields. What is the yield from the harvest, whether it's an apheresis or a bone marrow transplant. So it helps us to know the yield and how many of the hematopoietic cells we actually have. We will say CD34 positive cell, but in the layman is how much of the cells that we can transplant that will cause that new marrow to start producing the right type of marrow. So we need a minimum amount, and this stem cell lab helps to determine that. Two, sometimes you are not able to transfuse that harvest immediately and you need to store it. This stem cell lab also does all the preparation in order to make sure that we store them in the best ambient condition that will make us recover a full or close to a full dose or a dose that is enough to do what it has to. Now, there are sometimes that the donors and the recipients don't match exactly. Maybe the donors have some antibodies that the recipient might not be able to tolerate. So we do things we call manipulation. So if it is the plasma, that is the liquid form of the blood, that is likely going to cause the problem, we'll try to reduce that. If it's the red cell that might cause the problem, we try to reduce the red cell content. I'm trying to use a layman instead of saying major and cause. So we try to reduce that as well so that whatever we're giving to the donor is safe. We also ensure sterility of whatever we are giving to the donor. But we're able to do much more than that, which might not be necessarily related with the transplant. But because of the equipment we have, we can offer more. We have a multi-flow cytometer here, which is able to come in use in many diseases, both like in diagnosis of malignant disease, in prognostication, in monitoring disease. So we can actually do a lot of immunophenotyping with this machine. We can monitor minimal residual disease. So though it all came in because of the stem cell, but it's going to be able to provide accurate diagnosis, especially now that the management of hematological oncology have become so molecularly or genetically based. We will be able to offer much more than just the providing safe stem cells for sickle cell, but to a larger population of Nigerians will be able to contribute significantly to their management. So the harvesting the marrow, it's not within my preview, but I'll tell you what happens. We can harvest marrow either from the blood, which we call apheresis, and the person is linked to a machine that picks out just the cells we need and returns every other thing back to the patient. So the machine is taught to identify those cells. Or we can do a bone marrow harvest. In other words, we go into the bone because the bone is actually the factory where all the cells are. So you're likely going to get the seed. I'm using a layman that you need to plant on the marrow. When we do apheresis, we actually have to push those things out from the marrow into the blood. So we give some drugs to the donor so that we push those things in the marrow to the blood. But in the bone marrow, you're going directly to the source. And sometimes you can even use cord blood to do. We have no experience in cord blood for you, but I'm sure with time we'll get that. So when that is collected, it is brought here. Right from the donor to the recipient, sterility is important. So even when they are coming, the transporting bags must be sterile. Every procedure must be sterile, and it comes here. When it comes here, there are steps in what you have to do. We need to decide the volume of cell that was taken. We'll take samples to say, do we have the adequate cell dose? We'll take samples to say, has there been any contamination in terms of microorganisms? And then we do the count. Now, if we now need to do any manipulation, we do those manipulations as required. And then we calculate what is the cell dose per kg. We need to give them the information. Do you have enough cell dose? And if it is in bone marrow, halfway through the transplant, they send us and tell us how much we have taken and how much more will be. So we give them that within 10 to 15 minutes. You've taken this, you need to take this much more marrow volume. At the end of it, we've all finished processing. We need to be able to tell them 4 things. Number one, what is the cell dose? That means what quantity of those seed do we have, and is it enough, so that they will now say, oh, it's enough for what we need. We need to be able to tell them, do we have any not contaminants? What is the plasma, the liquid volume in that marrow? What is the red cell volume in that marrow? In certain circumstances, we don't want them to exceed particular levels. We need to be able to provide them. We also need to provide them how much of the things, we add things to make sure that the blood doesn't clot. When you kill something, the blood doesn't gel. So what we try to do is to add what we call anticoagulant to make sure that, so we also need to provide them information, what is the quantity of anticoagulant per bag? Because we also have the red flag, which we must not. And finally, we must give them quality control and say, what was our recovery rate? So at the end of it all, we should do that. Now, if they are going to transfuse back that day, then we send that. If they want us to stop, then we go to another procedure of how to preserve them in such a way that when we need them, we have viable cells. That is about a summary of what we do here in terms of the cancer. And for the Sickle Cell Foundation and Lagos University Teaching Hospital has invested a lot in training. Every arm of this stem cell process, people have been sent to understudy abroad with our technical partners. Our nurses have gone abroad to understudy, the lab have gone, the clinicians have gone. So everyone involved in this already have that primary degree as consultants and things like that, and have added knowledge on what they are doing in terms of what they have to offer. And so I don't think Nigerians should be afraid, because every one of us working here have been adequately trained, and will still have contacts with our technical partners. And that contact will continue, because a child learns and keep on learning. There is no end to learning. It's just that there's a minimal learning for you to start, but learning is a continuous progress. And because we have this collaborations, it ensures that learning is continued. I feel generally at large, the more we have curative methods available, the more we're able to reduce the spread of sickle cell. So what I have to say is that it's not just about you. If we can cure you as a sickle cell patient, we can also reduce the transmission of sickle cell. So there is hope. Though for now, yes, we are using some criteria to see who are those who are eligible, because we know that transplant has a risk. But the more people are able to afford the transplant, the more we're breaking the cycle of the spread of the disease. So I will also use what we need to call on Nigerians to donate, so that those who cannot afford, we can create a pool for those patients who sincerely need a transplant to be able to afford a transplant. Otherwise, we'll have the beautiful place that is only for the rich. So I will call on Nigerians to make donations to ensure that every Nigerian has the opportunity, if we need it, to be transplanted. Thank you.